Thanks for joining
Us
us.
and welcome to our Health Matters webinar series. I'm Michelle Levander, editor of reportingonhealth.org, a project of the USC Annenberg School for Communication and Journalism. We're delighted to have a distinguished panel joining us to speak about a quiet revolution taking place in healthcare today, a revolution that could transform how America pays for healthcare and consequently how care is delivered. Currently, most healthcare providers bill for each service. Now, Medicare is moving rapidly toward rewarding value rather than volume. But will this shift bring the expected cost savings and quality improvements anticipated by the Obama administration? Our panel will explore these questions. The panel includes Jordan Rao, a senior correspondent for Kaiser Health News and veteran health policy reporter, whose stories appear in major news outlets across the country. Jordan Rao's focus is on cost and quality of care. Dr. Arnold Milstein, director of the Clinical Excellence Research Center at Stanford School of Medicine. Dr. Milstein also serves as medical director for the Pacific Business Group on Health and heads up healthcare innovation development for Mercer Healthcare and Benefits. And Professor Austin Fracht, a regular contributor to the New York Times' is The Upshot, a health economist and co-author of the popular healthcare blog, The Incidental Economist. Frack works for the U.S. Department of Veteran Affairs, the Department of Psychiatry at Boston University School of Medicine, and the Department of Health Policy and Management at Boston University School of Public Health. Our Health Matters webinar series will be exploring this important topic thanks to generous support from the National Institute of Healthcare Management Foundation. Our panelists will be sharing their insights for about 45 minutes, and then we'll open up the webinar to questions from participants. Because we anticipate that hundreds of people will participate in the webinar, we've muted all your phones so that everyone can hear our speakers without interruption. If you have a question for one of our panelists or a technical question for us, we encourage you to enter it in the question chat field in the webinar GoToWebinar panel on your screen. You can also raise a virtual hand through your controls, and if time permits, we'll try to call on you to answer your questions directly. We'll also be taping this webinar, and you will find it archived on our website tomorrow. Shortly after the program ends, you will receive a short evaluation form. It just takes a few minutes to complete. Please do fill it out, as it helps us guide us in designing future programs. Please also consider joining Reporting on Health, our online community for journalists, policy thinkers, and healthcare practitioners. If you're interested in contributing to our online community, you can also contact us at editor@reportingonhealth.org. Our hashtag for Twitter for this event is #HealthMatters. Thank you, and now I'm going to turn this over to Jordan Rao.
Thanks very much, Michelle. So I'm just going to give a quick overview of let me just click this and make sure everything is going. There we go. All right. I'm going to give a quick overview of basically what pay for performance and value-based payment is about, and then let people who are much more expert talk about it. But just to give you a sense, and this slide is not advanced. Okay, there we go. So as Michelle said, the current method of traditional fee-for-service has been around for a long time, since way back when doctors were getting chickens for the work that they did for patients. And it was basically, right now, hospitals are paid per admission. So you go in for something, and if it's a more expensive procedure, they're paid one amount, and if it's less expensive, they're paid less, and doctors are paid per visit or per procedure. And this system has no link whatsoever to quality. The doctor can do a terrible job, can do a great job, they get paid the same. And I consider this, the accountability is about the same as a criminal defense lawyer. You're guilty, you're innocent, it doesn't really matter, they get paid exactly the same. And this is what health policy people have been feeling has to be changed, because the financial incentive here is the way that you get paid more is to do more things, to do more procedures, and to do more expensive procedures. And so things like stenting have become quite popular, and a lot of that, or some of that, has to do with the fact that the doctors are paid more for it. So the first phase that Medicare has been trying to change is keeping this fee-for-service method, but linking it to quality, so that you do get a little bit more or a little bit less based on your quality. And it's not a lot right now. It's about 2% on the upside and up to 6% down. But so hospitals, for instance, that have a lot of patients who come back within 30 days can lose money. Hospitals where the patients give them bad ratings or high mortality rates can lose money. Hospitals starting this year with with high rates of infections can lose money. So this is sort of the first phase, but it's still basically still your fee-for-service system. What the government and a lot of private insurers are hoping to move for are more radical changes of alternative payment methods. And these vary, but the idea is to get away from just paying for that amount. One idea are called bundled payments, where the providers get a set amount, but they don't just have to take care of just that procedure. For instance, if it's a knee surgery, the doctors will get a set payment for that. But that payment covers not just you going in and doing the surgery and the doctor's costs and the hospital costs, but also the follow-up rehabilitation costs. So if there's a complication or you need to do it again, they have to take care of that and eat that payment. Another one which has been talked about a lot, and I think we'll talk about a lot today, are ACOs, which are accountable care organizations. And these are ones where a group of doctors, hospitals, and other facilities take responsibility for all the patient's needs. And again, if they save money, they get a cut of the savings, and if it costs more, they have to eat it. So those are going on around the country right now. And then down the line, there's population-based payments. Maryland is doing this now, where you just get a set fee per patient. So it's completely divorced from actually what happens to the patient. This slide is from CMS, and it shows where they are right now. You can see that back in 2011, almost everything was in the gray was just straight fee for service, and then some was linked to quality, like the readmission penalties, and then there was no alternative payment models, but these were introduced as experiments as part of the health law. And then the goal on the far right side is by 2018 to have 50% in ACOs, bundled payments, and these other types of alternative payment systems, and then another 40%, making up a total of 90% in linked to quality, and just 10% left in fee-for-service. So that is my introduction, and now I think I'm going to turn it over to Dr. Milstein.
Thank you. Thank you, Jordan. I'll spend a couple minutes covering three topics. First, I'm going to spend a couple minutes talking about what might be a reasonable quantitative vision of aspiration to improve value in American healthcare, where value is defined by both quality and the total cost of care, both for an insurer and the out-of-pocket spending that a patient pays. Then I'm going to help you foresee, if were it to be the case that current incentives indeed motivate doctors and hospitals to produce more with less, what might be in the near term the nature of those changes. Then I'll just briefly touch upon what those changes might look like 10 years out, particularly as information technology platforms get better understood and used by doctors and hospitals. So let's begin with the first slide. Here's I had through a combination of my work both on the public sector policy making side and private sector side, if I were to summarize what I think are kind of the reasonable quantitative aspiration for, if all goes well in changing incentives, what is the nature of value improvement that the buy side of healthcare aspires to, and that for which there's reasonable evidence of its achievability. The first is that that annual growth in measures of quality of care in the U.S. might be boosted up a little bit higher than the average gain across quality care measures in the U.S., which is currently running about 2% a year. That is a figure that can be obtained from the Agency for Healthcare Research and Quality, AHRQ. They produced, at Congress's request, an annual U.S. healthcare quality report. And year in and year out since it's been produced, there's been about a 2% annual gain. I think the sense on the part of many people who manage quality in the U.S. in healthcare is that the pace of that could be picked up considerably, particularly when you look at the gap between average and best on most quality scores. The second is the notion of, well, how much, on a one-time basis, how much, if we were to simply replicate most efficient ways of delivering healthcare universally in the U.S., how much healthcare spending would go away. The Institute of Medicine has issued a variety of reports opining on this. I think the center of across most reports is there might be as much as a 30% opportunity on a one-time basis to lower healthcare spending. And for those of you who sort of follow, what keeps, whoever is CBO and director up at night, it's not so much the absolute level of spending as the rate at which it's outgrowing the economy. Traditionally, it's been outgrowing the economy by about 2 to 3 real percentage points a year. And so the idea is, if the incentives that Jordan described begin to kick in, could healthcare systems begin to improve their value at a rate sufficient to neutralize that gap between rate of growth in healthcare spending and rate of growth in GDP, the latter of which obviously is an index of our society's ability to afford anything. And it also, obviously, to the degree that healthcare outgrows the rest of the economy, it means that money comes from somewhere, and also many have observed that it appears to be a source of considerable sand being thrown into America's political gears. All right, so that's the aspiration. Just so you can get a mental picture of this, here's an effort that I chaired for about 10 years, in which we tried to get all the HMOs in California to synchronize on how they went about measuring and paying for quality among health insurance risk-bearing medical groups in California, of which there are more than 200. And we kept pushing toward 2 composite scores. On the vertical axis, you see a composite score for across a wide range of quality measures that the doctors felt were a reasonable way of judging their quality. Across the horizontal axis, you see what I call the health insurance fuel burn-o-meter. Think of it as sort of a miles per gallon rating, but an inverse version of it. Essentially, as you move from left to right, more health insurance fuel is being burned per person per year, adjusting for the risk and age and diagnoses represented by the patients that a given physician organization is taking care of. And each one of those dots is a different risk-bearing physician organization in California. And as you can see, there is, this allows what's called positive value outlier research, the number of names for it, but it allows you to kind of model, how much, at least within this group of diverse delivery systems in one part of the country, how much we might be able to lower healthcare spending and improve quality scores simply by closing in on today's positive value outliers, that is, replicating them. Okay, so that gives a sense of near-term possibility. If you were to look at what goes on inside these high performers, one might expect to see a different kind of care being delivered here than is average. And with support from the Peterson Foundation, the Peterson Center on Healthcare in New York, we were able to analyze across a number of different medical specialties and also across community hospitals what was actually going on differently in these positive value outliers. And I thought in the next slide I'd show you just very briefly a summary of what we found among primary care sites that were compared to their peers, achieving very favorable scores on available quality measures, but burning much less health insurance fuel per patient per year. And that fuel consumption doesn't only take into account what the primary care doctors were charging, but also their patients' use of drugs and emergency rooms and hospitalization and the like. And here is sort of this gives you a picture of kind of some of the ways in which healthcare was different. These practices in ways that obviously I don't have time to go into in depth right now, but they tended to have deeper, more personal relationships with their patients. Their patients trusted that if they called these doctors nights and weekends, someone who knew something about them would be rapidly responsive. These doctors' vision, their vision of their width of responsibility to patients extended far beyond producing a perfect office visit. It really meant being sort of a steward for their patients' best interest as their patients traversed emergency room doctors and hospitalists and medical specialists. And lastly, these doctors were not trying to be solo heroes. They did a wonderful job of hiring and training medical assistants and really taking advantage of a team and not investing much in physical assets. and it was associated with substantial improvement in value as described there. Our next step in this research is going to be to try to splice this DNA into average performing primary care practices and verify that this is indeed the right stuff. So let's now move just briefly to a question of what this might look like if we were to do such a study in any setting. I'm going to pick ICU care, but in 10 years, after American doctors and nurses and hospitals learn how to tame these information technology platforms that they are gradually getting to know. This is a study I think is really worth noticing, published by a team at the University of Massachusetts last year. Basically what it did is it took a look at what happened in 56 different ICUs across the country that decided to supplement their frontline ICU team with a remote control tower, analogous to what is in most American airports. And in that control tower were ACE ICU nurses, just like those that were in the front lines taking care of the patients, and also an ACE intensive care doctor, specialty, who could kind of. And the idea was essentially let's look at the same electronic feeds that are coming that the frontline team is seeing, but maybe just like in an airline control tower, having a little bit of distance from the front line might enable you to see things that can be missed if you're at the front line of clinical combat, as it were. And as you can see, the results published by Craig Lilly and his team showed that this particular deployment of in this case information technology really made a difference across 56 diverse American ICUs. I think if those of you who read Thinking Fast and Thinking Slow, you would I could conceptualize what was used as what Daniel Kahneman referred to as cognitive appliances. And also there was some interesting social science at work here in the use of heightened individuation, which I think I don't have time to get into, but I think it was my view is it was it had a major impact on the improved performance that we see here. This is just a little glimpse as to what high-value healthcare might look like 10 years from now, as opposed to in 2 or 3 years. In this case, looking at ICU care. I think it'll be making better use of both the information technology and human psychology. So, a few closing thoughts. First, I think politicians of both stripes and certainly the private sector, Business Roundtable, and I think organized labor as well, would sort of agree on this first point, that better, less expensive care is a national imperative. That the opportunity cost being imposed on the rest of society due to inefficiently delivered care is something that is creating enormous opportunity cost. As I've tried to show you, one way of understanding what the near-term opportunity might be to do more with less is through simply methodically taking a look at what's happening in positive outlier sites and doing it at a relatively granular level. We did that by sending independent clinicians on a blinded basis into a sample of physician practices around the country that were both ranked high on value and those that were ranked in the middle. And our blinded reviewers were simply asked to discern, what they thought that was unique about these sites, and then we fortunately found 10 specific features that differentiated the better sites, the higher value sites from those in the middle of the distribution. And I think, as I probably hinted, as I begin to think about what is going to be what are some of the sciences that'll get applied as if these incentives that Jordan described are successful in motivating doctors and hospitals and nurses to want to improve value, what are the sciences they are most likely to draw upon and apply? I think they're going to be a combination of behavioral science and computer science. Behavioral because healthcare is so much more than manufacturing; it's a highly intimate human service. And computer science because the complexity of modern medicine is such that it is really, I think, outstripping the ability of ordinary mortals to not only figure out which treatment makes the most sense in a given point in time, but also apply its many intricate steps in the kind of perfect way that's necessary to to do the best by patients and do it efficiently. Let me stop there and turn things over to Austin.
So thank you. As I wait for my screen to be shared, I'm going to start with a question, which is, why are we measuring and paying for quality or value, or why are we moving in that direction? And that may sound like an obvious question with a simple answer, but if it's so simple, why is it a relatively new idea? So I'll let you think about that. We've already heard the standard answer to why we're doing this. Let me just stop for a moment and ask, I don't believe my screen is yet shared, is that right? Terrific. Okay, so let me move forward to where I am. The standard answer we've heard earlier is that we want to pay for value or quality, measure it and pay for it, because what we've been doing is paying for volume, and that leads to incentives to use more care, overuse certain kind of care, and particularly care that's of less value. And that's obviously not something we want. And that's a great answer. It's totally fine. I have no problems with that answer. I'm going to give you a slightly different answer that's complementary. It doesn't conflict. And I want to go back to the past when Medicare has cut payments to providers. Let's think about hospitals. And let me just say, when I talk about cuts, and usually this is what people mean, we're not talking about actually changes in level, but changes in growth rates. So instead of, say, the payment that Medicare might make for a certain kind of hospitalization going up by 5% next year, a quote cut might have it only go up 3%. That's what I'm talking about. Medicare's done that kind of thing in the past many times. And studies have shown that the results aren't always good. Bad things can happen when Medicare cuts payments. And why is this? Well, when hospitals are paid less, they have to cut something. They're not just going to sit there and take less money and do the same amount of stuff, generally. So the question is, when they cut something, is it the right thing? What we want them to do is cut the less valuable, hopefully even wasteful care that's of no value whatsoever. But the fact is, going into the past and looking at what's happened, that has not always been the case. And so there are studies that show that when you cut payments to hospitals, it can lead to higher mortality and other bad outcomes. And so that's something we should be very concerned about. By the way, at the bottom of most of my slides, you'll see a little thing that says for more, see something, and there's a hyperlink there. When the slides are available and you download them, you can click on those and get more information about each thing I'm talking about. So I'm going to tell you an alternative story. When we cut Medicare, we should have this concern, or even if private payers cut their payments to hospitals, should have this concern that hospitals might cut back in ways that harm patients. So Medicare is going to be cut under the Affordable Care Act, and by quite a lot. So this figure is an illustration of the kind of cut I'm talking about. And what this shows is that relative to the rates that private insurers pay, those for Medicare and Medicaid are going to trend down over time. In fact, by the middle of the century, they're projected to be about half what private health insurance pays hospitals. And there's a similar figure that I'm not going to show for physicians. Now, there's a lot of things I could say about this chart, but one of them is that if the past is any guide, and this does come to pass, we should be concerned that quality may suffer unless we do something about quality. And that's really why we need to focus on quality as we're cutting payments. So, and what we want to incentivize hospitals to do is to become more productive. And where this chart comes from and why these payments are going down relative to private health insurance is from something in the Affordable Care Act called the productivity update. And what that is that the program, Medicare, is going to look at the economy-wide productivity, how much more output is happening in our economy for the inputs. And they're going to say to hospitals, we want you, or we're going to assume you're going to be as productive, your productivity gains are going to be as high as the rest of the economy. And if that's the case, we can go ahead and cut your payment rates commensurately. And so instead of having to cut back when we cut your payments, to do less stuff that might lead to harm, we're expecting you to be able to do just as much with less money over time. So the question is, can hospitals do that? Well, historically, they've never been able to do that. So here's a chart. Granted, it ends in 2005, and I'll come back to that at the end, what's happened in recent years. But here's a chart that shows the economy-wide productivity. That's the top line, the dashed line right at the top, and its growth rate, percent change each year. And then the next two lines that are almost the same are just two different ways of looking at hospital productivity. And I'm not going to go into what those ways are, and it doesn't really matter because they're about the same. The point is there's a huge gap between what the economy's been doing and what the hospital's been doing in terms of their productivity growth. Hospitals have never, at least as far as this time series is concerned, have never kept pace with the economy in terms of their ability to become more productive. And so this assumption built into the Affordable Care Act, the hospitals will become more productive, well, we don't have good evidence they can do that. So this is a big concern. And this is why, in addition to the cuts that are in the law, there are lots of incentives to improve quality, improve value, to nudge hospitals and the rest of the system toward greater productivity. That's really what it's all about. And that's the whole ballgame. So the question is this time different? Are we going to get different results from the past? And there's a whole bunch of different ways the law is trying to boost productivity. I'm not going to go through these in any detail at all. I've just listed some. ACOs, you've heard about, they've been mentioned. There's quality measurement, value-based purchasing, bundled payments, penalties and bonuses tied to quality, new IT capabilities, and it's not just Medicare that's doing things. There are private side innovations like Blue Cross and Blue Shield of Massachusetts is doing their alternative quality contract, AQC, and there's lots more in the links at the bottom of this slide. So this time might be different. All these things are trying to encourage productivity. Unfortunately, that's not all they encourage. They also encourage, they don't require, but they do encourage consolidation in the industry. So that's different mergers and integration of all types, and it is rampant. So lately, and it does predate the Affordable Care Act. I don't want to suggest that the new law is the only thing that's encouraging consolidation. Consolidation has been happening, but the law does have some incentives in that direction as well. So we're seeing more hospital mergers and acquisitions. We're seeing physicians coalescing into larger groups. 20%. There's 20% more physicians in groups over the last 25 years. That's ignoring those that are employed by hospitals, which is another trend. So hospitals are employing more physicians. There's about a 50% increase in hospital employment of physicians in the last dozen years. There's more integrated delivery systems developing and offering insurance products. That's another kind of integration when delivery systems kind of bundle with insurers. So there's consolidation and integration going on in lots of different ways here. And studies have shown that these kind of activities tend to push prices up and costs up, and they rarely improve quality. Now, there are examples where they have been found to improve quality, but it's not guaranteed. Just to give an example, hospital consolidation can increase prices quite a bit, and sometimes up as high as 40%. So this is a big concern. And here's a chart of hospital consolidation going back to 2000, which clearly predates the Affordable Care Act, but this shows the number of mergers and acquisitions in the bars. The number of independent hospitals has been trending downward, and the number of hospitals in systems with 5 or more members has been going up. And what I want to say about this is that when hospitals consolidate, so hospitals kind of come together with other hospitals, this is an area that has been studied most extensively out of all these kinds of mergers and integration. And there, it's pretty clear that prices go up and quality does not improve. There's just a ton of literature on that. Other kinds of consolidation is a little bit more ambiguous. So this is when hospitals employ physicians, form integrated delivery systems, offer their own insurance products. That's other kinds of integration. There, generally, prices go up as well, but quality sometimes goes up, not always. And so a key question is, for these kinds of integration, and these are the sorts of things you might see form into ACOs, if quality does go up, but prices do as well, is the additional quality worth the additional price? And that's the big question, and that's the productivity question, right? We're paying more, or somebody is, but maybe we're getting more, and what's the trade-off? So where this is happening most, or where a certain kind of integration is happening most, and I'm talking about delivery systems or providers offering insurance products, that's most common in Medicare Advantage, it turns out. Most of the plans that are offered by provider groups are offering them in the Medicare Advantage market, but they do exist in other markets as well. And I looked at this with some colleagues. We looked at the effect of Medicare Advantage plans that are offered by providers. We looked at the price level, the premium level that they offer, their quality as measured by Medicare, and also their benefits. And we found we observed no change in benefits, so they weren't offering more benefits. Their premiums did go up, and so did their quality. But their premiums went up well above what could be justified by the additional quality. So about 70% of the premium increase couldn't be accounted for by the additional quality. So our conclusion is that even though we were getting a little more from those kinds of plan provider that kind of plan provider integration, we're paying a lot more for it, and it may not be worth it. And this is important because the U.S. delivery system runs on markets, and you know, almost all the providers are in a market except for maybe those employed by the VA, and therefore prices really matter not to Medicare because Medicare sets prices, but prices matter to those of us who pay premiums through insurance products through the commercial market. And spending growth has been shown to be driven by price growth. So the Institute of Medicine found that 70% of spending variation is due to markups. This is price markups as opposed to quantity or input costs. And recent spending growth, although it's been trending downward, has been driven by prices. And these are all a signature of consolidation. As the market that we rely on consolidates, you should expect higher prices. Studies have shown that's what you get. That's what we're seeing. And this compromises public and private efforts at cost control and possibly quality improvement, because when you have fewer competitors, each one of them maybe have a little less incentive to push quality up as much as they might otherwise. So we need to look at this, and we need to pay close attention, particularly if we want to keep spending growth under control. It's prices where we need to look. That's what these results are showing us. We need to focus on prices, not quantity, demographics, or input costs. So let me wrap up, let me wrap up with a comment about whether I'm a skeptic or an optimist. I'm kind of both. I mean, I find what I just went through very troubling. Just based on prior research, cutting payments to providers can be dangerous, and I worry about the effect of consolidation, which is clearly going on. And yet I'm still cautiously optimistic because maybe this time is different. Things are different than they have been. We really are trying some new policies. We really do have some better information systems. And it's not completely unreasonable to expect different results. These are all the things, or many of the things, most of the smart health policy minds have thought we should try, and we are trying them. So we'll see. David Cutler and Peter Orszag, I think they're smarter than I am about this stuff, and they're pretty optimistic. I want to recommend David Cutler's book, Quality Cure. It's a great book. I think I linked to it at the bottom of this slide. And in it, David Cutler expresses optimism, but cautious optimism. He doesn't say it's a lock. He doesn't say we're going to get higher productivity for sure, that all these new payment methods and measuring and paying for quality are all going to work out. But he thinks there's a good chance. He also says, don't expect it overnight. It's going to take decades. I think he has about a 15 or 20 year time horizon on this. So we really are probably not being realistic to think, well, hey, the Affordable Care Act passed in 2010, and hey, it's 2015 already, and think everything should be great. It's just too soon. We should give things quite a bit more time than that. What we also shouldn't do is just assume everything's going to be great. We shouldn't just guess. We shouldn't make empty claims. We should do research. We should really study what's going on and find out how things are going. Now I want to show you some recent research published in Health Affairs just last month that is very encouraging. This is a chart of productivity gains by hospitals for 3 conditions. Productivity here is measured in a really nice way. Now, productivity is usually what you get versus what you pay, right? It's output over input. It's a ratio. That's kind of like miles per gallon. Like what you get is miles and what you pay is the gas, right? So you put the gas in and how many miles do you get out? Well, here, what you're putting in is dollars, and what you're getting out for these 3 conditions are measures of 30-day survival after the discharge from the hospital without a return to the hospital in that time. So how long, it's measuring over time, how long Medicare patients discharged with these conditions stay out of the hospital and alive, whether they do that for 30 days. Actually, in this study, they looked at other time intervals too, but this chart's for 30 days. And what you see here is that productivity was pretty bad, actually negative in some cases, for quite a while. And then it turned up, and it's been accelerating. And now the productivity gains by the end of this period are quite a bit faster than overall economic growth or economic productivity gains, which is exactly what we need and is exactly what the designers of the Affordable Care Act assumed hospitals would be able to do. So, and it's what you'd expect they could do if there really is as much waste as everyone says. It's a matter of them finding that waste and cutting it out as their payments go down or don't go up as fast. So this is very encouraging. I think this is a great study and something worth looking at and paying attention to. It is just one study. There's lots of other ways to measure productivity, and we should do that. So I wouldn't say this proves everything's great, but I'd say this is the kind of thing we should be grateful for if it does pan out. So we should do studies. We must study these issues rigorously. Research is our best, if imperfect, guide. And I'll end there. Thank you.
Great. Now we're going to go back to Jordan, and he's going to share a few ideas for stories that reporters can think about as they analyze all this.
Great. Thanks, Michelle. I wanted to talk a bit about, on a very concrete level, about the type of stories that have been done and can be done that are good. And there's a couple of challenges. I mean, the first challenge, you've actually been spared some of the worst of the acronyms and jargon by some very kind panelists. But when you start writing about things like accountable care organizations and patient-centered medical homes, you can just snore people to death. And that's always been a big challenge, particularly before some of these things launched, because you were just describing them in the abstract. Fortunately, we're at a stage now where accountable care organizations, bundled payment projects, bonus and penalties for hospitals and soon for doctors are all actually launching. And so they're things that we can write about contemporaneously, and more importantly, specifically, and papers all over the country have already started to do that. The most basic story is you go and sort of embed with a practice that's doing this and interview doctors and patients and tell their stories, and you can bring this stuff to life. A lot of this is really helped by the fact that Medicare has put up, and I'm going to mostly talk about Medicare here because that's where the information and the data is, and that's what I'm most familiar, but these things are also going on a less transparent way by private insurers. Medicare has put up an enormous amount of information for them on these projects. The map that you see here, they actually have a map on their site. The link is at the bottom of the slide, where you can search all through the country where individual projects are going on, all different types. You can search by geography, you can search by the type of the project. You can see in the little box here, you can choose which one. If I want to just look at Medicaid emergency psychiatric demonstrations, I can find them. And you can also download them, which is a much easier way to do it. This is just one of the databases that Medicare puts up, and so you can find the location of it, you can find who's running it, you can find what county it's in. So it's a great way, wherever you are in the country, to figure out, well, if I want to write about this, where can I start? And it also helps see the fact that these aren't going on everywhere. There are pockets where a lot of doctors and hospitals and nursing homes are taking part of them, and then places where they're not. I looked at this like a year ago, so this information is outdated, but there was a crazy number of bundled payments in Western Pennsylvania. So if I were a reporter in Pennsylvania, I would be really interested in writing about that and finding out what that is. Now, when you write about it, I had an editor who used to always say that you just want to sift the policy out. You just want to get rid of it or minimize as much in the stories. And so that's what we try to do. And this is a story that I had just done pretty recently for NPR. And it looked at the bonus and penalties for hospitals based on quality, which is a program called Hospital Value-Based Purchasing. And that name is something that whenever I try and stick it into a story, one of my editors just screams and wants to drag it out. And so what we did, we wanted to see how hospitals are doing in the third year of this program, where if they get bonuses, they get it for a lot of things. But in this case, we just wanted to look on patient satisfaction, how they were doing in terms of improving their patient satisfaction. And the way that the government measures this is that they send out surveys to patients after they leave, or actually the hospitals send them out, then they're reported to the government. And they ask questions like, how well did your nurses and doctors communicate? Was your pain well controlled? How would you rate this hospital on a scale 0 to 10? Would you recommend this hospital? And so what we did was we sifted through all the data, and we took a look at which hospitals had not improved from the start of public reporting until most recently. And so we narrowed it down and ended up talking to Novant Health System, which is a well-respected system in North Carolina, that let us go into one of their poorly performing hospitals. And this is one of the things you would think that they wouldn't. Hospitals don't do this, but I've actually found them surprisingly receptive to this. And so we went around and we interviewed people, and we got great examples of people who went in thinking they were going to get one surgery, and this woman got a different surgery. Another guy that said that you know, he had been treated like a dog the last time that he was in this hospital, but it had improved. And so we really kept the story you know, by grounding it in just one place and as many people and doctors as possible, we came up with, I think, a pretty interesting story for people. And this is just an example. This slide shows what those scores look like. If you just want to look on an individual hospital basis, you can go to Hospital Compare and type in, you know, location in the hospital, and you can see for each one of the issues that I described before what the score of the hospital was, how many patients said that they always got good communication, what the state average was, what the national average is. So you don't have to have an advanced degree in computer programming or R to do these type of stories. Another way, so that's a way of accessing stories through patients and through quality, which is, you know, the most, I think, the thing that most easily resonates with readers or viewers or listeners. Another way to do it is through the institutions themselves. And every year now, Medicare is giving out these bonuses or penalties or judging, which we'll get to in a little bit, these new projects. And so that's an annual way that you can do these stories. This is a story based on one round of fines that Medicare gave out for hospitals based on readmissions, when these hospitals, 28 hospitals in the St. Louis area, had too many patients readmitted, so they were fined. And, you know, whenever you write about hospitals, it's a great story to do because they're often the largest employer. Everyone knows the hospitals. And so by putting specific numbers to these types of stories, you know, specifically with the amount of money or the percentage, you can really, you know, make them very interesting stories that people pay attention to, as opposed to if you just write vaguely about, say, readmissions, and then, you know, people may go into readmission. Now, what I think is most interesting and is being done in various places is on some of these alternative models that we talked about. There's actually an enormous amount of data, and what CMS is putting up is not just their quality scores that they're following, but also are they saving money or losing money? And they've been putting up the evaluation. And so some really good stories have come out of it. This one I found in the Valley News, which is a paper that sits on the Connecticut River. Well, the paper doesn't sit on the river, obviously, otherwise it would be waterlogged, but its circulation area is along the Connecticut River on the New Hampshire and Vermont border. And I put this up also, and you saw an Oberholm paper. These are stories that can be done really well, if not better, than by local papers or local radio stations than nationally, again, because it's all about getting to the specifics. And Valley News did a great job. They took a look at these numbers, and they saw that one of the ACOs run by Dartmouth-Hitchcock Medical Center, which is the provider, the most prestigious place in the area, had not done well originally and had losing money. So they got a great story. I don't know where this story ran in the paper, but I would be surprised if it didn't run on A1 out of it, very specifics. And then obviously they could drill down into that, and they went and they interviewed people and, you know, why is this? And this can come, you can get this information really easily either as simply or as complicated as you want from Medicare. This is the easy way. They've got the site where you can see the link below where you can just type in an ACO name and you can look it up and it comes out and it looks like this. You can see the quality ratings of a hospital, and once you get into quality ratings, then it starts to get complicated because you've got to understand them. But just to take a look at one of them here, the first one, the hemoglobin A1C control, that's for diabetes patients and their blood sugar level and how well the hospital or the ACO rather did. And in this case, 80% had their blood sugar levels below what the target was. So, and then you also see over here on the right side the patient reviews where they're asking patients. One of the downsides of this is, as you can see, there's no comparison to what a national standard is. So for that, you have to download the data, and it gets a bit messier. But again, this is just something you can do with Excel. You don't need fancy stuff. And I sort of made it a little bit prettier here, but this is the database, and you can see in this case, here's an ACO, and tells where it is. It's in Nevada, when it joined an ACO, and then it shows how many beneficiaries, how Medicare people were in it, what they aimed to make, what they did save, how much of a savings they got, and then each of their scores for all of the different ACO quality measures. And then if you average everyone, you can see if they were higher than lower. So that's a very large overview of just the type of stories and the type of data that's out there to do those stories.
So now we're going to turn to our audience. And the first question that we have right now is from Casey Quinlan, an investigative editor at U.S. News. And he doesn't direct it to any one of you. So if one of you wants to take a first shot at it, that would be great. He says, given the gotcha RE billing coverage reimbursement that patients are subject to, why can't there be a stronger, faster timeline on shifting to value, like 12 months or die trying? So do any of you want to give that a try? He adds, by the way, the healthcare system seems incapable of transforming itself out of a cash cow arms race.
Well, this is Austin. I can say that there's considerable risk in trying to move things too quickly. I don't disagree that there's a long way to go, and lots of patients are hit with high bills, particularly if they're uninsured. But even nowadays, when they're insured with high cost sharing, and they're not always getting the quality they deserve, and or the respect. Frankly, I think customer service in our health sector is abysmal. All that should change, and I would love it to change overnight. But if you try to do that with financial incentives, there's a lot of risk involved. Nobody wants their community hospital to shut down, go out of business, because they can't change fast enough. And like I said earlier, there are studies saying if you just cut payment, you could get worse outcomes, not better. So I think the best view of what we're trying to do is develop the right structural approach, or trying different approaches to see what might work, and then gradually over time put more and more teeth into them so they bite and bind and push the system in the right direction. But it is going to take time, and I'm not the only one saying that. And I don't think that's because anybody wants it to take so long. I just think it does take so long. It's a very large sector with a lot of stakeholders and people who are slow to change, and it's just the way it's going to be.
Maybe this is Arnie Milstein. I can just add one thing, and that is, I think the reason I think that Austin's answer is a good one is that this is not a sector that has previously been subject to intense competition on value. And so its ability to be agile and manage performance quickly is simply starts out at a level far below what one might see in intensely value competitive industries, like, for example, chip manufacturing, where if you can't keep up on value relative to your competitors, your sales drop relatively abruptly, and it's do or die. But this is not a sector that has been subject to any kind of comparative benefit from delivering higher value, and so its management capability and its tools are in a fairly early state of development.
Thanks. We have another question here from Barbara Fader-Ostrov, a freelance journalist. She asks, can the panelists talk about whether they think patient-reported outcome data, and she clarifies not satisfaction surveys, will show, or affect how health providers are paid for care? Are they becoming more important, or are independently confirmed measures like hospital readmissions more important?
Well, maybe this is Arnie. I'll take a crack at that and say that I think that many people would say that that is the ultimate the ultimate judges of value ought to be the patients who are subjecting themselves to the risks of healthcare and their report on how the degree to which they can function better as a result of a healthcare intervention. That being said, we are quite a bit away from having the information systems and data collection and data capture strategies to be able to do that. We are making, other countries have made progress. For example, some of the Scandinavian countries actually check up with patients, a year and 5 years after hip surgery and find out whether or not, they can walk without pain. And you see the very beginnings of this in a few, progressive places around the country. For example, out here in California, a number of progressive healthcare purchasers and orthopedic surgeons have begun to build what's called a joint, in this case, joint replacement surgery outcomes registry, in which one of the measures is not simply whether you, in addition to asking whether you can actually sort of get out of the hospital without suffering a severe complication, they are indeed checking up with patients at certain intervals following the surgery to see if indeed they can walk better and walk without pain, which is, I think, the ultimate source of value in healthcare.
This is Austin. I could add a little bit to that. The question or the issue of what's value in healthcare, how to measure it, as well as deliver it, is just a huge one, and it's raging all over the place these days. If you ask, a dozen health policy experts or healthcare experts what's value, you'll probably get 24 answers. And in fact, I was involved in a process that did essentially that. We had about a dozen people brainstorming in a session about what value is, and we had an enormous list of what it could possibly be, including patient-centered, or patient-specific and reported measures, and ones that are more generated from administrative databases, potentially more objective. And you can look at it both ways. I agree that the patient is the most important person in the room, and so their assessment of value is highly germane. On the other hand, the patient is almost never paying the full cost. You and I are, through our taxes, through our premiums that are shared. And so our sense of what's valuable for other people is relevant. We don't want other people using our dollars, our contributions, for just anything they find valuable. We want it to be objectively high quality, and that's rational and reasonable as well. So there's a lot of ways to look at it, and they're all valid and sensible. And I'm not sure anybody's figured out quite how to combine all those perspectives.
Thank you. We have a question from Jacob Molyneux, senior editor at Wolters Kluwer Health. He asks, nurses on the whole seem to perceive that nurse staffing is being cut and that other pressures in terms of shift work are being applied to staff nurses. They see this as tied to Medicare cuts, at least partly, and they also see it as a real danger to patient safety and quality of care. There's more and more data supporting a link between nurse staffing and quality of care. Would this only get worse even as the burden of quality measure documentation tied to reimbursement continues to increase for nurses?
I think it's a very good example of why it's important as these incentives for both efficiency and for these incentives for efficiency get increased, that there be offsetting or neutralizing incentives that would make efforts to economize in ways in which quality would suffer, to make it fruitless for those who would pursue efficiency in that dysfunctional manner. So it gets at all the challenges in moving forward, which is that are our current measures of quality what we ultimately want them to be? No, they are not. Are they good enough to start, given the relatively mild incentives for value that are currently unfolding? That's a judgment call. My personal judgment is that they are good enough given the relatively mild incentives that are initially being applied to improve value.
We have two sort of similar questions, so I'll read both of them. One is from Andrew Sprung, an independent journalist for Austin Fract. What do we know about ways to offset bad effects of consolidation? And then from Roger Smith at the Center for Health Reporting, what carrots and sticks is CMS adding to achieve the alternative care goals by 2018?
They're both for me?
Well, if someone else wants to chime in, that's fine too. The first one was aimed at you.
Okay, I'll take the first one, and then I'm not even going to remember the second one, so we'll have to have that repeated. So here's the problem with consolidation: is once it's happened, there's not a lot you can do. There's antitrust enforcement, but that's a really it's kind of a patch. If you really want if you want to build a strong house, you have to start with a strong foundation. So what you'd prefer is to have policies that don't promote consolidation and to begin with, and then go from there. And unfortunately, as the chart showed, we have like decades of consolidation going on. I mean, not always in one direction, but it has predominantly been toward more consolidated health systems in the U.S. And so now we're at the point where I'm not sure that's going to be completely undone. It's certainly not going to be undone overnight. I think for some kinds of things, scope of practice relaxation can help. Having clinics available, in retail settings can help, but that's not going to help for things that require hospitalization. So I don't have a complete answer. We have some tools, but we also, have a system that is highly consolidated and probably not going to. That's probably not going to change very quickly.
Michelle, I can take the second half of Roger's question, which is how's Medicare going to reach these targets? And they're basically going three ways. The first is they've got what they call the Innovation Center, and this is where they're trying out lots of tiny pilot projects. I mean, there's an enormous number with crazy names, but sending physicians to homes of patients proactively so they don't have to get admitted, things like that. And they're trying to judge them, and if any of these turn out to be successful, they want to expand them. So you're basically letting 1,000 flowers bloom. So that's one way. And so these experimentations will work. Hopefully the bad ones would fall by the waysides, and the ones that right now are just being done by a couple hundred providers would go national. The second thing that they're doing is they're expanding the mandatory part of the programs, these linking to fee-for-service. They're expanding those from just beyond hospitals. They're now going to large doctors groups. They're going to be going to nursing homes. They're going to be applying to everyone. So a lot of when you see those targets, what they're doing is they're just bringing in all the post-acute providers and the other providers. And so those are two of the ways. And then the third way that they're doing is that they're hoping that the private sector will get very heavily involved as well, and that ideally private insurers and the government would be offering the same type of incentives, same type of financial repayment, and so therefore there would be even greater incentive for these hospitals and doctors and such to switch over.
So folks, I want to thank this fabulous panel, and I want to share that we have hit the 1 hour mark for our webinar. We're going to be posting all these materials, the PowerPoints, the video of the webinar, and some resources shared by our speakers tomorrow on our website. And if you registered for this webinar, you'll all receive that. Jordan Rao has generously offered to stay a little longer, but I know that Dr. Milstein and Professor Fract are going to have to sign off now. I also want to just mention that if you as a participant need to jump off, please know that we'll be sending you a quick evaluation, and please take a moment to fill it out as this helps guide our planning for future webinars. Thank you, Jordan. Thank you, Professor Fracht, and thank you, Dr. Milstein. So now we're going to turn to another question. This is for you, luckily, Jordan. It's from Jenna Flanagan. She says, you mentioned that in some cases a journalist would need to have a deeper understanding of hospital quality measures in order to work with CMS data. Do you have suggestions for resources that journalists can use to learn how to report with the CMS data effectively?
That's a great question. I think that, on a basic level, if you go and you look at their website or if you just Google around, you can get a good sense of it. But when you want to when you're doing your reporting, I think that that's one of the important things that you want to talk to the providers on the ground about, because they will tell you the benefits and the problems with it, and some of them are more controversial than others. Also, obviously, reading other stories about these measures are important. If you really want to go wonky, you can find the measure developer and ask them to explain it to them, and that's actually not as difficult or unpleasant as it sounds. But the reason that you want to understand the measures is you want to understand what they do and what they don't tell you. And there's a couple of areas where it's important. The first thing is that a lot of these measures end up reporting everyone back as average, and there are legitimate statistical reasons for that, but you want to understand that. You want to be very careful. For instance, just to take the patient experience surveys, you don't want to go all crazy if you've got a hospital that's got a 68% favorable rate for, will they be recommended for by other patients against a national rate of 70%. It's just not that big a deal. So you want to know how to take the things in perspective. Then the second thing that you want to be aware of is that a lot of these, depending on the measure, a lot of the hospitals, the doctors, the other people will say that there's something specific about their patients that gives them such a lousy rate. Sort of the banner example of this is readmissions, where there's pretty good evidence that hospitals that take care of a lot of safety net patients, a lot of poor patients, tend to have higher readmission rates, and there are reasons behind that. And so you don't want to just go out and say, well, they've got a high readmission rate because they're doing a terrible job, because there might be other reasons. So in the course of the reporting, you need to really get a handle of that. And like I said, I think it's done the way you would report on anything, which is, you deal with the people you're interviewing, you find good experts who can talk in English. And a lot of times the complication itself to the measure, the complexity or the vagueness can become the story. For instance, for readmissions, it's just as interesting story. Why do low-income people tend to be readmitted more? That's just as interesting a story as lots of hospitals in my area are getting punished for having high readmission rates.
Great, thank you, Jordan. Here's another question from Brad Stewart, who's a physician and describes himself as a healthcare re-engineer. He says, what can journalists do to alter public perception that mortality rates are the most important metric of quality? Much waste occurs in overtreatment of seriously ill seniors.
Well, that's an interesting one. I think it's always debatable what is the most important measure, and I think the answer is there's probably not one. It's hard to argue with the idea that a mortality rate isn't important, but there are other ones that are really important. Overtreatment, one of the problems with the measures is it's the old spotlight phenomenon, or the lamppost phenomenon, that you look for the keys where you can, or whatever it is. I'm mangling it, but there's some things that we're getting pretty good at measuring. Mortality, patient surveys, the things I've talked about. There are other things like overtreatment that the ability to measure is really not quite there, and that's a frustration because journalistically you go where you can report on. So mortality rates have been out there for about as long as anything, so we write about them, and plus they're easy to understand. There are other things that are very complicated. So basically, I think that if you write about mortality rates, you do have to put them into perspective, and the best thing to do is obviously just not write about one thing. But I think that people just journalistically, people are going to be attracted to things like infections, like mortality rates, things that have direct patient safety links.
Great. We have a question we'll take two more questions. This one is from Eileen Beal. She's a freelance journalist. Many hospitals now are for profit. How does that impact the monetary findings that the two presenters were focused on? When hospitals' investors aren't happy, how does that impact delivery of care? My gut says they cut staff, et cetera, to get their investments. I don't know if that feels too much like a question for Professor Fracht for you, Jordan, or if you want to try and tackle it.
Well, I wouldn't go too specific except to say that, we've looked a lot at, and journalistically and also the experts have looked at the difference between for-profit and non-profits. Remember that the majority of hospitals in the country are non-profits. And a lot of times we see that they actually behave very similarly. Nonprofit hospitals are very competitive. They may not be going for profits, but they're going for margins and, to have as much of a surplus as possible and for market share. And the financial incentives that go downwards, working at them can be just as good or just as bad. So I would say that it's always dangerous to look at the profit status alone, because there are going to be places that are going to do really well and do a good job in terms of dealing with tightened finances that are for profit, and ones that are going to do a good job that are nonprofit, and conversely there are going to be ones that are going to do poorly of both. Not that it's not an element to look at, but I think it's dangerous to generalize.
So Jordan, here's a final question, kind of more of a policy question than a journalism question, from Matthew Gilden, senior analyst at Chilmark Research. He asks, how are consumers going to legitimately shop for healthcare services given the current state of quality, safety, and pricing information available to the public through CMS, private payers, or third-party efforts?
It's a great question, and I think the answer is no one really knows. On the quality front, CMS has been putting up quality measures since 2007, and the evidence seems to be that people don't use them that much. The reality is that people still tend to equate higher cost with better quality, even though, as was pointed out, that's not really a correlation. And then, of course, there's the problem that you basically defer to your doctor a lot of times, particularly if it's a very grievous thing. It's not like shopping for a car, or you don't have the time to. So I think that there's a lot of stuff that I'm not an expert on at all, of sort of behavioral economics of how to get people, when they choose an insurance plan or choose a doctor or choose a particular procedure, how to get this into their head. But that's all in the very early stages, I think, of success.
Well, so Jordan, I think we're going to wrap it up here. I want to thank you for staying a few minutes longer to answer some of these additional questions. And I want to thank all the participants for your excellent questions. I think it really helped add to the discussion toward the end. I want to just remind everybody that we'll be sending you a link to the archived version of this webinar, and we'll also ask you to fill out an evaluation. And if you want to get more involved with Reporting on Health, please write us at editor@reportingonhealth.org. We'll be announcing future webinars, and we want to thank you all for joining us. Have a great day.